So I'll be talking about how to set up a peripheral bronchoscopy service, the steps that you should consider. So before, let us have a look on the evolution of the interventional pulmonology, which is a very growing very, very fast the last years. And if we look at the history of the interventional pulmonology, we started by, it was simple instruments that was used by Kilian in 1890s, which he was the first that was able to visualize the airways, and he was able to remove foreign body from the trachea. Following his experience, Jackson Chevalier was an American ENT. He was also able to have the same experience. In the year 1960s, with the development of the fiber optics, Ikeda developed the fiber optic bronchoscopy. And then we had the radial probe EBUS, the cone beam CT, and the electronavigation, the cryobiopsy, and now we have the robotic bronchoscopies. So we have the impression that we are going through the same transition as the gastrointestinal, as the GIT, like 2 or 3 decades, because all these technologies have reduced the need to perform laparoscopic exploration or video-assisted biopsies. So we're going really more and more towards the less invasive procedures. But what is the real challenge? The real challenge is that we have an increase in the number of diagnoses of peripheral pulmonary nodules. One, because it is related to the increase of the quality of imaging and to the lung cancer screening programs that started already in the United States, and it's coming in the near future in Europe. Well, the problem is these nodules are still a challenge for interventional pulmonologists, because you will see the 3 techniques with which we can have a lung biopsy are surgical, CT-guided biopsies, and the bronchoscopic or minimally invasive endoscopic procedures. So this is a summary of the endoscopic procedures with the costs. If you look at the radial probe EBUS, which costs, I think, a little bit more than 40K, it's about 120K. The diagnostic yield is about 70%, with a complication rate about 3%, while the electronavigation, which is much more expensive, the diagnostic yield is 77%. The robotic bronchoscopy, around 1 million, and the diagnostic yield, we are at 84%. And finally, the hybrid room, which is 1.2 million, and it is an aiding tool for performing lung biopsies. But did we really, although all the technology we have today, did we really improve the diagnostic yield? So this is a very interesting paper that was published in the Chest Journal in 2023. So they actually analyzed all papers published before 2011 and after 2011. So before 2011, with all the technologies we have, including the robotics, so 39 studies, 3,052 lesions versus 13,535 lesions. And the answer is no, we did not improve the diagnostic yield. Who performs lung interventions? So we have 3 techniques or 3 specialties that are concerned by the peripheral pulmonary nodules. We have the thoracic surgeons, so lung biopsies. But the advantage of a lung biopsy for peripheral nodule is that it is diagnostic and therapeutic at the same time, while the inconvenience is that we will operate patients for malignant nodules. So 20% of patients that are operated undiagnosed have a benign lesion finally. The second technique is the CT-guided biopsy, but we have more risk of pneumothorax, bleeding, and pulmonary air embolism, and the interventional pulmonologies with the technology that I have showed you. So how to set up a peripheral pulmonary nodule service? What do you need? Actually, let me ask you, what do you need? If I'm your director, hospital director, what do you need? What's the first thing that comes into your mind? Any idea? Money? Probably. Why? Because you need slim scopes? radial probe, electronavigation, robotics, or hybrid room? Well, actually, yeah, you need money, but I developed the 6 steps approach to develop how to set up the peripheral pulmonary nodule service. Money is one of them, so you need training, you need to build a team, you need the equipment, and you need the money, set up your protocols, you need to have the patients, and finally discuss patients in MDT meeting. So what training is? Training concerns medical and paramedical teams. So I'm not aware of a single workshop that is dedicated for nurses, for instance. And this can be done by courses, workshops, hands-on. And the most important, you need to know your anatomy by heart. It's like going from point A to point B without GPS. If you don't know the way, you will never reach. The second step is team building. As you saw that we need to reunite, the future relies on the reunion of specialty or organ dedicated. I mean, we need to have the thoracic surgeon, the thoracic oncology, the anesthesiologist, and the interventional radiologist, because we need to discuss every patient who will have a CT-guided biopsy and who will have an endoscopic technique. The third step is the equipments. And when you choose your equipments, I prefer to use the 3 steps approach. What's the 3 steps approach? You need a navigation tool. So this is the tool you will use to go from point A to point B, which is the Ultraslim scope. You need a confirmation tool, like the radial probe EBUS. And you need a biopsy tool, like the cryo or the forceps or the needle. You need to write down your protocols for patient selection, for the procedure, the anesthesia protocol, because we know that anesthesia protocols, they play a major role in improving the diagnostic yield, especially when we use cone beam CT to improve the quality of imaging. And set your protocols for complications management like bleeding or pneumothorax. The 5th step is patience. You need to have patience. If you have the robot tomorrow and you don't have patience, your program will not work. How can you have patience? You need to attend MDT meetings, you need to contact the referring physicians, screening programs, and above all, you need to improve your diagnostic yield. The last step is the MDT meeting, where you will be discussing every patient and you will be discussing, assessing your results. All set? Yeah. Now you need to evaluate your practice, change, improve, train. By train, I mean train others, innovate, and then you go on and repeat. So how did I develop our peripheral pulmonary nodule program at my hospital? So I initiated the program in 2017, where I went to Sami Lashkar in Rouen and I had a training with him. And then I trained my nurses, so I built a team, we bought the equipments and we started. 2020, I saw that actually our numbers are not increasing, so we were doing like 30 or 40 patients per year. So for a program that started 3 or 4 years ahead, it's not really satisfying. So I'm like, okay, let's see what's wrong. So I had a look on our diagnostic yield and I found that we are at 40%, we have 40% diagnostic yield. So I went to my direction and I'm like, I cannot see a patient and tell him that he has 1/3 chances to have a positive biopsy. So we need to change it. It's either we stop the program or we buy some other equipments to improve our diagnostic yield. So we invested. We got the Ultraslim, the cone beam CT, because it's a tool that is actually shared by other specialties. We have dedicated nurses. We discuss patients in MDT meeting, and we did a wide collaboration with the thoracic surgeons, the interventional radiologist, and the anesthesiologist. 2022, we innovated, we trained, and we did research. We developed the cryobiopsy. We had our first workshop in peripheral nodules, and we did research on this topic. So this is the translation of what we exactly did So 2017, 2018, if you see the curve till 2022, we had 40% diagnostic yield with 40 patients per year. And when we improved the diagnostic yield, automatically we increased our recruitment. So my conclusion is that how to set up a peripheral pulmonary nodule service, the 6 steps approach, training, team, equipment, protocol setting. You need patients. You need to discuss them in MDT meeting. And when you're done, you need to evaluate your practice to change, to improve, train others, innovate, and repeat. And I'd like to thank my team for the wide collaboration we have together. That is a very important point in the success of our program. Thank you.
Thank you, Amir, for that very informative talk. Thank you. Does anyone have any questions for Amir? Yeah?
Thank you. Great talk.
Thank you.
If it was to remake the same road, but knowing all that you like and mislike during this experience that you accumulated, which would be the main machines that you would buy, especially for guiding the PPN approach? Thank you.
Depends. I think that the Ultraslim scope, the radial probe, and the cryobiopsy tool are this is the best diagnostic yield with the lowest cost. Now, without CBCT, okay. The main problem is the tool in lesion, the last 1 centimeter. If you have the CBCT that is shared with other specialties, that would be great. But I mean, for now, I don't think it's very, your directors would not accept to have a CBCT dedicated for the IP. But you can have the mobile C-arm, and it works very well as well. So I would choose the Ultraslim, the radial probe, and the cryo. If I have 3 tools.
Okay. Any other questions for Amir? No. Thank you very much.
Thank you.
Thank you.